We now begin Lecture 29, Cardiovascular 3, the maturation and partitioning of the heart. This is an anterior view of a neonatal heart with the lungs attached. We see the cut edge of the reflected parietal pericardium. So we would be inside the pericardial sac or space between the parietal and reflecting onto the surface of the heart, the visceral pericardium. The visceral pericardium would also be called the epicardium. So we note first the right ventricle is positioned primarily on the ventral or anterior surface and the right lateral side. The left ventricle is primarily on the left anterior and lateral side and posterior. We note the auricle of the right atrium with the superior vena cava draining into it. The inferior vena cava's cut edge would be here. The auricle of the left atrium, and of course the pulmonary veins would be draining in posteriorly. We see emerging from the conus of the right ventricle the pulmonary trunk that will of course divide into the right and the left pulmonary arteries. We cannot see those. They are covered by the parietal pericardium reflected superiorly here. And then from the left ventricle emerging from behind the pulmonary trunk is the aorta. So the ascending aorta would be this first short portion from which would branch, of course, the coronary arteries, the right coming right in here into the right atrioventricular sulcus, and the left emerging from behind or posterior to the pulmonary trunk and residing here for a short distance before it bifurcates within the the left atrioventricular sulcus. So the left coronary artery would be right in here. And it branches, and we see the left anterior descending in the anterior interventricular sulcus between the right and the left ventricles. So the marginal vein would be draining on this side here, and then posteriorly into the coronary sinus, also draining into the right atrium. So we recall that this was a single output channel of the embryonic and fetal heart, embryonic, by fetus it's close to this, and the two atria were joined with a single input at the caudal end. So this was original cranial, this was original caudal, and that's what we will follow. But first, let's see the change from neonatal to adult heart. So the first thing we notice is that in the space just under the epicardium or the visceral pericardial layer, visceral pericardium, we see the glistening epicardium or visceral pericardium, and the fat has accumulated in the right atrioventricular sulcus, on the pulmonary trunk here, and in the anterior interventricular sulcus. It can be much worse than this, but this is what we do to our heart over time as we age. We see the left auricle of the left atrium just protruding a bit here, and the right auricle of the right atrium here. The pulmonary trunk, of course, and of course the ascending aorta with the arch of the aorta and some of the first branches coming from that. So in this case, we don't even see the coronary arteries because they are covered in their entirety with this adipose deposition. With a coronal section through the adult heart, we can see the four chambers: the right atrium, right ventricle, left atrium, and the left ventricle. So remember, this was a common output, and these two were joined as a common input. So we have to mold and fold the heart to make all these separations. We start with the right atrium. We see the superior vena cava coming in, and the inferior vena cava coming in inferiorly. The coronary sinus would drain in just about here. The interatrial septum is located here, and it's very important. We'll follow the development of that in this lecture. We would have to slip one finger behind the aorta back here and our thumb here, and we could palpate that thin interatrial septum. We see the interventricular septum, very muscular and thick, especially relative to the interatrial septum. We see the right atrioventricular or AV valve. We have three cusps. There are two cusps shown here. One is removed with the anterior portion of the heart. So the tricuspid is the right AV valve. The bicuspid, we see one valve here. And the bicuspid is the left atrioventricular valve. We see semilunar valves, two cusps here. There's a third cusp removed, pulmonary semilunar, and in the aorta, again the same, aortic semilunar valves. We see two left pulmonary veins draining into the left atrium, two right pulmonary veins coming behind and also draining into the left atrium. So we know the blood flow simultaneously, venous return into right and left, and then through into the ventricles through the AV valves. And then when the ventricles contract, they close the AV valves and they force the blood out through the pulmonary and aortic semilunar valves to be distributed. So this is the adult picture in our mind. We followed the development of all these vessels in previous lectures, and now we will focus on the development of the heart. So there are initial contractions, and they consist of muscular peristalsis, as we had said before, and it begins in the sinus venosus and proceeds rostrally to empty out at the arterial end. So this occurs basically the same. The atria are going to contract in the very end to fill the ventricles, stretches them, and then the ventricles are going to contract and eject the blood through the arterial end of the heart. So things haven't changed there, and the final thing we'll look at in this lecture is the development of the conducting system in the heart that conveys the signal and controls that flow of contraction. So by the end of week 4, the flow is unidirectional. It's not basically sloshing back and forth kind of with a bulk flow from venous to arterial end. It now is very strongly unidirectional with no backwashing. So the sinus venosus through the sinoatrial valves, through the primordial atrium, through the atrioventricular canal, through the primordial ventricle, through the bulbus cordus, through the truncus arteriosus, through the aortic sac, through the aortic arches, and finally into the dorsal aorta. So we will follow the development of the heart in that way, looking at these structures first. So this is a figure that we looked at previously, where the heart tubes have fused together in the midline, and they further develop to become a bit contorted as it elongates and can't fit within the pericardium, kind of crunches on itself is a way to think about it. There are localized thickenings, and we'll look at those more closely. So this labeling is wrong, and our task is to correct it. So we'll flip between this slide and the next slide. This slide shows the figure from our text, and we see the blood flow, venous return from the common cardinal veins that would have come as well from the other veins feeding into this system, but we'll follow the common cardinal veins draining in. We see that there's already a sinoatrial valve between the sinus venosus and the primordial atrium. We see these local thickenings generating a small decreased diameter lumen passing through this area, the atrioventricular canal, obviously between the atrium and the ventricle, and they are the dorsal and the ventral endocardial cushions. These are these elevations that occur, and we'll look at them from a variety of views to follow how they contribute to the separation of the heart into the 4 chambers. Then the blood flows into the ventricle. So let's go back to catch up. Here are the would be the common cardinal veins into the sinus venosus, into the primordial atrium. The atrioventricular canal would be here. This would be the ventricle. So we see the ventricle, and now we see the next part is the bulbus cordus, leading into the truncus arteriosus, and finally the aortic sac, where the pharyngeal arches, arteries, are branching. So here's the first aortic arch, and they, of course, open into the dorsal aorta. So we back up. This is the ventricle, the bulbus cordis, the truncus arteriosus, the aortic sac would be here. It isn't labeled, and of course opens into the first and second aortic arches shown there. So you'll have to identify these numbered structures. Now if we stretch the heart to the rostral and the caudal portions, kind of stretch it out like a little worm, we have the rostral end. We're looking at a ventral view, so this is left and this is right. And what we notice with the ventral wall removed, that just as we get into the sinus venosus and the primordial atrium, there are some ridges that are developing, these elevated structures. These we will follow, be very critical in generating the interatrial septum, and right now they are key for directing the flow through the primordial heart. And there will be these other elevations that will become important as time goes by. Now, with a cross-section through this area, at this level here, the atrioventricular canal, we can see that at 28 days, the endocardial cushions are present, and over time, the delta T here, change in time, to about the 35th day, we see that those endocardial cushions will meet and separate it into a, they switched their L and R on this here, but a channel on the right and the left. So we're going to separate it and send the blood flow through the corresponding sides. So atrial, left atrium to left ventricle, right atrium to right ventricle, and these are all primordial structures. So the mature circulation then is dependent on the partitioning of the heart compartments during weeks 4 through 7, and we'll see this in figures from our text as well. So we saw the endocardial cushions. They're on the dorsal and ventral walls of the atrioventricular canal. They fuse and divide the AV canal into the right and left halves, and we'll see that in another figure from our text. So these become ultimately the atrioventricular valves. They will develop further the cusps that we saw and all the connections to other muscles in the ventricular wall and the interventricular septum. The septum primum divides the right and left atriums. So we basically saw those in the previous slides, but we'll introduce them in more detail as we proceed here. So figure 1411, A through C, these are schematic sketches of sagittal sections of the heart during the 4th and the 5th weeks, illustrating the blood flow through the heart and the division of the atrioventricular canal. The panel D will be a coronal section of the heart at the plane shown in panel C, and we want to note that the interatrial and the interventricular septa have also started to develop. So these things are occurring all simultaneously. So this is the one we saw before, just actually a little bit earlier than the one we saw before, and the endocardial cushions have not quite developed to narrow this channel yet. Now we see they're approximating each other and narrowing the atrioventricular canal. And finally they touch. So we saw this in cross-section and in with this all stretched out in a ventral view looking up this way. So we know that there's additional ridges that have developed both on the dorsal and the ventral surface. They start growing upward and downward toward each other in the midline. So in a coronal cut, basically through like this, in this plane here, it's kind of oblique, I guess, we can see the sinoatrial valve guarding the orifice of the sinus venosus. So this would be the sinus venosus. The foramen is present now between the right and the left atrium. We see a septum primum developing, protruding down in from dorsally. And we see the fused endocardial cushions. And so the blood can pass between this foramen on the two sides, the right and the left side of the primordial atrium, called the foramen primum, excuse me. And the blood flow is bidirectional around those on either way. So there's obviously more turbulence going in this direction, so the bulk of the flow would be the path of least resistance. So right atrium to right ventricle. But for now, they just want to continue getting the flow through the heart. And then we see the developing interventricular septum down here at the primordial apex of the heart. They're also showing these changes in the wall of the ventricular chambers. We saw those in the picture of the adult heart, and we'll see it again briefly later. So the mature circulation is dependent, as we said. So the primordial interventricular septum divides the right and left ventricles. We saw that occurring. Neural crest cells migrate to the bulbus cordis, causing the bulbus cordis and the truncus arteriosus to spiral and divide into the aorta and the pulmonary trunks. So we'll follow that in figure 1421. So we showed how the adult, the neonatal and the adult pulmonary trunk and aorta are related to each other. They kind of spiral around each other, and we'll see that in this figure 1421, how it develops. The semilunar valves form as the truncus arteriosus is being partitioned. So let's take a look at this effect in the ventricles. So what we're seeing here is so we have a cross section through the ventricle, and we see 28 days, 35 days, and 56 days. And so there is this infolding that is the interventricular septum, and it keeps bulging and pushing until it makes contact, fuses, and forms the complete septum between the right and the left ventricles. The coronal view is shown below, and we can see the muscular interventricular septum bulging in from this area here, and the atrioventricular canals has been separated by the endocardial cushion. So I already see the four chambers beginning to appear here. We see that the interventricular septum progresses, and there's a narrowing at this area here. You see it starts to look like a cross, so this is called the crux or the cross of the heart. It's where the four chambers join together. So we see that the atria are being separated and the ventricles, and the atria are being separated from the ventricles. So this slide is showing us this similar illustration, except our planes of section are now through the atria, and we're looking at the interatrial septum development. But first, let's identify some of these structures. So this is the septum primum that we saw. So the septum primum is shown here. And then the septum secundum is developing here in blue. And this creates the two foramina, or ostium. The one located right here is the foramen ovalis. It's an oval foramen between the two atria. And when we come down here, we see the ostium secundum. So we saw the ostium primum before, and once these extra bulges come in here, the septum primum joined by the septum secundum, we get the second ostium. So two routes of blood flow are shown here. The orange is the in utero. The blood pressure differential is greater in the right atrium than in the left atrium. And at birth, of course, that changes, so it actually reverses, so that the blood pressure is greater in the left atrium than it is in the right atrium. So we have a greater pressure in the left atrium. Their labeling is messed up here again. Um, and what this does is it forces blood flow through from the atrium to the ventricle, straight through from the right side. I'm sorry, they do have it labeled correctly. This is the right side. So that we said that the path of least resistance is straight through right atrium into right ventricle, and then it takes greater pressure in the right versus the left, and there's more turbulence, but we do get flow across from right atrium to left atrium and through the left ventricle. So in this way, they're acting in concert to produce the one-way valve. And then this foramen ovale will become the fossa ovalis at birth. So we can see the differences in the planes of section as we proceed through time. So these are the delta t's, the delta times, and we are seeing that the septum secundum will lose its contact and have a little flap there. And days 28, 35 to 56, we get this progressive change in these, so that we finally end up with a complete interatrial septum. Now we are looking a little bit more rostrally here at the separation of the truncus arteriosus into the two output vessels, the great arteries or arterial trunks. And we have planes of section here that show the two major vessels. So the aorta and the pulmonary trunk are shown. So they're going to end up twisted around. So the aorta is on this side and the pulmonary trunk is on this side. So the aorta ends up on the right, although it comes from the left heart, and the pulmonary trunk ends up on the left, even though it's coming from the right heart. And then there's a point where they cross each other, where the pulmonary trunk is anterior to the aorta, positioned posteriorly there. And then they again reorient, so right is on right and left is on left as they attach to the corresponding ventricles. So the way that this occurs is that we have the two channels created by this spiraling elevation, and the right, of course, is the pulmonary channel, and the left is the aortic channel, and it spirals around to give this final situation. So this cushion is creating that type of a spiraled effect if we try to look at this area three-dimensionally. So the blood flow is spiraling around until the vessels become two completely separate structures. So from which structures do the semilunar valves develop? So they are from swellings of the mesenchyme of the pulmonary and the aortic channels. The right truncus swelling, the right bulbar ridge is produced. The left truncus swelling is the left bulbous ridge. And the minor truncus swellings, there's two of them, and there's also, or they're called the dorsal and the ventral swellings. So a series of swellings come together to form that spiraling separation, and then also continues to develop to form the three cusps of the semilunar valves that get separated into the three for the aorta and the three for the pulmonary trunk. We also see the atrioventricular valves, as we had mentioned before, the right the tricuspid, the left the bicuspid, and we see all these ornate attachments to the papillary muscles in the myocardium of the ventricles, corresponding ventricles. And of course, the chordae tendineae are these tendinous types of attachments to the cusps of the valves and they prevent the valves when they're closed due to the contraction of the ventricles. Increasing pressure pushes back in this direction, closes them, and then these attachments, these papillary muscles, contract the same time as the ventricles do, and they prevent the regurgitation of blood into the atria, and also they prevent the prolapse of these cusps up into that area, because a high pressure is going to be developed, as we know. So we can take a peek at how these valves develop. What we see first is that we can see the interatrial septum developing, and now we're looking at this anterior view. We see the septum primum has remained small. The septum secundum has grown in, and it's a lot longer. This is what we saw in the previous slide. And the ostium secundum is formed here, and then this is the foramen ovale. So the ostium secundum will close completely, and the foramen ovale will also seal, but it should just be a fossa and becomes a fossa ovale. A fossa is a shallow depression. Then we see at the crux of the heart the endocardial cushions, where they came together and separated the atrioventricular channels. And there's slight protrusions on the side. These will continue to protrude and develop into the atrioventricular valves. We also see the beginning of the interventricular muscular septum here at the apex of the heart, the tip of the heart, and the endocardial cushions. So this is going to continue to develop toward the crux, and it does so, and then meets close to the crux. So this membranous interventricular septum shows us that the development is from apex to the base of the heart. This wider part is the base of the heart. And so when we look at defects, we'll see that this is a primary spot where there is a defect. So the sinus venosus will ultimately become, on the right side, the sinus venerum, another name for the smooth part of the right atrial wall. The left will become the coronary sinus, as we mentioned before. The bulbus cordis, on the right side, it becomes the conus arteriosus, the smooth part of the right ventricle, leading to the pulmonary trunk, also called the infundibulum, funnel-shaped. And the left bulbus cordis, once it's separated, will become the aortic vestibule, part of the left ventricle wall leading into the aorta, just below the aortic semilunar valves. So this is figure 1412. It's a schematic drawing of the developing heart, showing the partitioning of the atrioventricular canal, the primordial atrium, and the ventricle. And it'll take us through so that we see as well the progression, days 28 in panel B, to 32 in panel C, to 35 in panel D, and then E will show us at 8 weeks. So we'll also be able to follow the development of the atrioventricular valves in this series of slides. So we see the entrance of the pulmonary veins over here in the left atrium. We see the sinoatrial orifice with the valve of the sinus venosus. We see the ostium primum, the foramen primum, either way. Both terms are correct. And this will undergo changes, so we get the septum secundum and the fossa, the foramen ovale, and the ostium secundum. We see the endocardial cushion has separated into the atrioventricular canals to the right and the left, and the interventricular septum is beginning to develop so that it will separate the ventricles. As we proceed, then, we see the foramen secundum has developed. The foramen primum is basically disappearing. The septum primum is still here, so we're awaiting the septum secundum to form the foramen ovale down here, so the blood would have to flow in this circuitous kind of a direction. We don't want a great deal of pressure coming to the left side because we don't want it pushing back in this direction. So that was that previous slide, to keep the high pressure flowing from right into right and then out and then back through left, and then getting some guidance from this to push it into the left ventricle, and then the left ventricle ejecting it through the aorta. So there's obviously a great deal of turbulence in the blood here, and these pathways have to be created in such a way that they support the unidirectional flow overall, from right side through left side. And we do have pulmonary circulation, as we know, because the lungs are developing basically at the same time. So now we see these left atrioventricular canals. These little bulges are beginning to form at the edges around its circumference. These obviously are going to be developing into the AV valves, but the interventricular septum is approaching the fused endocardial cushions. We see the septum primum, the foramen secundum, and the septum secundum is just starting to push itself down in. Now we see it very nicely here, and we see the foramen ovale here at the inferior free margin of the septum secundum and the right edge of the septum primum. So it's around in this area, and we have to have the pressure drive it through this oblique space, through the foramen secundum, from right atrium into left atrium. So most of the flow is going to come in this direction still, because it's path of least resistance. You see the inferior edge of the septum secundum, as it has, of course, is really circular to create the foramen ovale. Well, it's oval to create the foramen ovale. So we now see the mitral valve and the tricuspid valves are beginning to develop. We see the papillary muscles, so the attachments and everything are created very early on, and they all develop simultaneously. So the derivatives of the septum spirium of the embryonic heart, the limbus of the fossa ovale, and the valve of the coronary sinus, and the valve of the inferior vena cava. So these septa end up persisting in the adult as a leg of the oval fossa, where the foramen ovale closes off. The coronary sinus has a little valve on it to direct the flow into the toward the right AV valve, and then the valve of the inferior vena cava also doing basically the same, swirling it up around so that it will bend and come down into the right AV valve. So here we are looking in the left atrium. So we see the mitral or bicuspid valve and the left ventricle. So here is the muscular wall, and we see the papillary muscles of the chordae tendineae attaching to the cusps, and this is the left atrium cut open, and at a higher magnification we can see it here. So this is the edge, the narrowing of the atrioventricular canals, or channels, and this the mesenchyme in this area continues to develop and bulge in and forms a connective tissue layer. Remember that all of these structures, you see it moist and glistening, are covered with endocardium, the endothelial lining. And then here we're looking from the left ventricle at the aortic valve, so we see the cusps, 1, 2, and it looks like the third one here. And here we see the left coronary artery exiting just at that attachment there. And we're looking from a more superior view here down into these cusps. And then from the superior view, we can see them as well. So these are the AV valves. These are let's see, anteriorly. Wait. This would be the posterior surface, anterior surface. So anterior, this is pulmonary. Posterior, this is aorta. This is coming from the right, and this is coming from the left. So these are the aortic semilunar valves, a posterior, a right, and a left. And the pulmonary has an anterior and a left and a right cusp. So name the septa and their openings, which separate the common atrium during the development of the heart. So the first, the primary septum, or the septum primum, and it has the ostium primum, and it also forms the ostium secundum. The septum secundum, or the secondary septum, forms the oval foramen, or the foramen ovale. So which septa are formed in the ventricles and the truncus arteriosus? There's a muscular interventricular septum, a membranous interventricular septum that we saw, and the aortico-pulmonary septum that we had mentioned that spirals around. And they collectively contribute to the separation of the heart into the four chambers. And so we can see the direction of the blood flow. So at first it's just peristaltic, but kind of sloshes back and forth a little bit. And then finally it goes through the single chamber from venous end. So this is sinus venosus. This would be a horn of the sinus venosus. This would be the sinus venosus. This would be the primordial atrium. We got to back up, don't we? Sinus venosus, primordial atrium, ventricle, bulbus cordis, and the aortic trunk. Did I get those right? Truncus aortis. And then we see this develop further and has a little spiral through it. And then finally there's the twist and the turn, but still unidirectional. And then ultimately we see the venous return and the two atria coming in. Here we can follow it through the inferior vena cava, and the superior vena cava goes to the right ventricle, and then out through the pulmonary trunk to the lungs, so it circulates through the lungs. And then at the same time it's going to the left side and out directly out the aorta. So what are the blood flow changes at birth? So let's take a look at this slide. It's not in your set. I've added a few, but that's fine. So first we take a look at the fetal circulation and then the newborn. So the fetal circulation, we see the systemic venous return to the inferior vena cava. Also, the venous return, they have the right color this time, and the umbilical vein coming through the liver, and the ductus venosus shunts it straight into the inferior vena cava. The inferior vena cava opens into the right atrium, and we have the superior vena cava draining in as well. They're not showing the sinus, the coronary sinus, but the venous drainage of the heart comes in as well. And the flow, especially coming from the umbilical vein, is almost straight to the foramen ovale, and it is basically kind of shunted into the left atrium so that it can get into the left ventricle and be sent out through the aorta. So in this way we get the nutrient-rich and oxygenated blood mixed as little as possible as this cross circulation through the right atrium, get it to the left atrium. Then it's mixing with pulmonary venous return also in the left atrium in the ventricle, so they've lightened the red color. So there's a bit of dilution of things there. And we will follow the right side again, venous return into the right atrium, out through the pulmonary trunk to the lungs. So it also has taken on a slightly pinkish hue, but not as oxygenated as in the aorta yet. And as well, there is the ductus arteriosus between the pulmonary trunk and the arch of the aorta. So we're shunting pulmonary circulation into the aorta as well. And again, we lose a little bit of the red color in the rest of the aorta from there on out, as it's distributed systemically to the body and the other parts. So in this way, we are getting as well from the pulmonary trunk the pulmonary circulation to the lungs. So the lungs are receiving their nutrients and oxygen and so forth, but also having the blood supply developed by having flow through it. We want this system to be operational. Remember that as well, through the diaphragmatic and thoracic muscle contractions, the lungs are being filled with the amniotic fluid. So the whole system is operational, waiting for the fluid to be cleared out and the air to begin moving in and out. All the circulation has to be in place. We know that the ductus arteriosus is going to become obliterated to become the ligamentum arteriosus. In addition, we know that the foramen ovale is going to become the fossa ovale as the primary and secondary septa fuse together and close off the ostium secundum, or the secondary foramen. In addition, of course, the ductus arteriosus is going to become obliterated as the umbilical cord is lost and the umbilical vein breaks down. Actually, it just fills up with connective tissue and is no longer a patent structure. And so we end up with the ligamentum venosus, the obliterated ductus venosus, and the umbilical vein becomes the ligamentum teres hepatis, the round ligament of the liver, going to the umbilicus. And then we see the umbilical arteries. Remember, they became the internal iliacs. So we see the two umbilical arteries here, carrying blood to the chorion, the placenta. So they will become obliterated when the umbilical cord is lost, and the umbilical arteries become the medial umbilical ligaments that we had mentioned before. We recall that the urinary bladder has the urachus that also extends into the umbilical cord for a bit, and it becomes the medial, it becomes the median umbilical ligament when it becomes obliterated. So at birth, we have those changes in the umbilical arteries, the umbilical vein, the ductus venosus, and the ductus arteriosus. So they all become obliterated, and we have the full four-chambered circulation. Here we are looking at the pulmonary circuit. So our venous return, systemic venous return from the right through the right AV valve into the right ventricle, out through the pulmonary semilunar valves, through the pulmonary trunk, into the right and the left pulmonary arteries, through the capillary bed of the lung, oxygenated, and then returned to the left atrium, through the left AV valve into the left ventricle, out through the aortic semilunar valve to the systemic circuit that we'll look at next. So remember that the filling of both atria happens simultaneously. Then the ventricles are filled. Then the emptying of the ventricular chambers occurs simultaneously as well. So as you're pushing a column of blood out of the ventricle, that column of blood is continuous, so you're getting venous return at the same time you have output. Some pressure is built up, but still there is a constant column, so you have flow all the time. It isn't this, come in here, go out there, and then finally get back here, and then finally go out there. It's filling at the same time you're ejecting, and then filling, final filling here, and then you eject, and you're filling over here pretty much at the same time. Both right and left hearts doing that at the same time. And then both circulatory systems are shown here. The systemic circulation is shown here. So venous return from the head and neck and upper extremities to the superior vena cava. Inferior vena cava picking up capillary beds of the organs and the other structures in the thoracic cavity. The capillary bed of the liver being formed both by the hepatic artery from the celiac trunk and the pulmonary, and the hepatic portal system. So there's a hepatic arterial supply, and then through the intestines, the hepatic portal venous drainage both feed into the capillary bed of the liver, into the inferior vena cava. So we talked about that intrahepatic inferior vena cava just below the diaphragm. and then, of course, the rest of the vascular beds to the abdominal organs and other structures in the lower extremities. So now we can briefly discuss the conducting system of the heart. So there is the sinoatrial node, the atrioventricular node, and then there are bundles that run in the intramuscular septum. So the SA node develops during week 5. It's originally from the sinus venosus. The AV node develops superior to the endocardial cushions, and the fibers from the nodes pass through the atrium to the ventricle as the right and the left bundle branches. And the well-developed muscular conducting system is innervated and active prior to the innervation by the autonomic nervous system. So it develops its own intrinsic circuitry before it has a well-established extrinsic drive to it. So we know that these structures are modified cardiac myocytes, so it's not surprising. And cardiac myocytes have an autorhythmicity. So the SA node is the fastest autorhythmicity, so it's the pacemaker, the natural pacemaker. The AV node is a little bit slower, so it's driven by the SA node. And so this drives the heart rate. So here we see an illustration of the adult heart. So the sinus venosum would have been in this area. So this is where the sinoatrial node develops. And although there aren't any anatomical fibers identified, there is a conductive circuit that radiates out from there, and it all converges ultimately on the atrioventricular node, the AV node, at the base of the intraventricular septum, right at the crux, but it's more on the right-hand side. And then there's a single bundle that runs through the crux of the heart into the upper part of the intraventricular septum. Basically, remember the membranous intraventricular septum was here, so it passes through there. That's the bundle of His that we know it by. And then it splits into the right bundle and the left bundle that deliver the signal in that direction. So we start with the SA node and the AV node, and then we get the spread from the SA node on out through the atria. So at this point, the atria are going to contract and give the final filling of the ventricles. Then the AV node will begin to discharge, send the signal down through the conducting bundles, the bundle of His, the right and the left bundles, finally to these Purkinje fibers that deliver it to the smaller clusters of cardiac myocytes. The contractions begin at the apex of the heart, and then they will proceed kind of in a spiral direction, but from the apex toward the base or the crux of the heart. And that way it builds the pressure, closes the AV valves, the papillary muscles contract, prevent regurgitation and prolapse, and create a pressure differential across the semilunar valves in the pulmonary and the aortic systemic circulation. And you get that pressure differential. These open, boom, the chambers, the ventricles empty. So that completes our discussion of the development of the heart.